I'm going to go through a brief introduction, which is this, a case scenario, because the ethics of blood transfusion tends to focus on one thing in particular, but there are some other important stuff, as you'll see down the bottom here, which we'll also get to. So, we need to start by deciding what ethics is all about. Can anybody give me a shot at what's ethics? The science of right conduct, doing things the right way, behaving in a right manner, especially when it comes to how we work as physicians or nurses or people in general. Everybody should behave in an ethical way. And usually, it sort of refers to how you behave, how you carry yourself. And people talk about people being good or not good people. And it's how you carry yourself every day. It's not just when you go to work or when you're in the lab. Wherever you are, you should behave in an ethical manner. So here's a case scenario. One of your good friends, whom you've worked with and known for years, is walking through a crossroads and she's hit by a car. She has pelvic and femoral fractures. For the non-medical or nursing staff, that's a bad thing. That means they're losing a lot of blood already before they've even got to hospital. And you may not see this blood loss because it can be internal. She arrives in accident and emergency, and she's awake, she's orientated, she knows where she is, she's in pain, and she says she doesn't want any blood products. She's a Jehovah's Witness. What now? Water. Water, well, actually, you don't want to give her any water. She needs to be nil orally, because she's going to be in my hands shortly as I put her off to sleep. What are the options? She's going to lose a lot of blood. If she loses blood, there's a chance she could die. Hands up all who are going to let her die. Serious question, not a rhetorical question. We're faced with this situation in the hospital on a regular basis. How many of you, given the fact that you are now in charge of her management, would give her blood to keep her alive? 1, 2, 3. And hands up, who would let her die? That's the option. You're going to give her the blood, or she's going to die. Are there any other options? You're not going to give her blood? Okay. Aggressive treatment. Right, but she says, no, I would rather die. But you actually have the blood in your hand because a very keen medical student took the blood before she said she was a Jehovah's Witness. So in the theater, in real life, when the surgeon is operating and the hemoglobin falls and there's blood all over the floor, there will come a point when if you give the blood, she will most likely live. And if you don't give the blood, she will almost certainly die. And you have to make that decision. Any of the physicians in the room and medical students. So, and they don't like when I say this, but if you don't give the blood, she's going to die. All right, so let's have a little think about what would guide us in this. The 4 principles approach by Beauchamp and Childress in approaching ethics is a set of principles that I like to discuss. There are other ways of looking at ethics, virtue ethics and other things like that. But autonomy, beneficence, non-maleficence, and justice. Autonomy means the patient or an individual has the right to determine what is done to them. And we're all autonomous. And as I always tell people, but with autonomy comes responsibility and accountability. Beneficence, you're familiar with, it means doing good, which we always try to do. Non-maleficence means not doing harm. And the reason we have both of them in the group is that everything we do in medicine, every single interaction we have with the patient, no matter how good our intentions, does have the potential to cause harm. And justice means treating everybody fairly without regard to race, class, color, sexual orientation, whether you live uptown or downtown. And it's also, in our sense, which is very important, we talk about distributive justice. We have very little of anything in this country right now in medicine. And the little we have to share fairly between everybody, giving to who needs it most without regard to whether or not you're light skin, dark skin, JLP, PNP, anything at all. So leading on to informed consent. As the young lady pointed out, you have a right to say, I don't want this thing, or I do want this thing. So it's an agreement to do what I or any of the other physicians or nurses suggest you do. An informed consent, well, before I get to that, there's no English statute setting out the general principles of consent, but common law or case law says that if you touch a patient without their consent, you can be accused of battery, which is a civil and/or criminal offense. From an ethical point of view, if you breach that, then you've also reached autonomy. You've taken away the right of them to decide what is done to themselves. You're not doing good, and you're certainly causing harm. Also, if subsequent to whatever you do, the patient comes to harm and takes you to court, that will have some weight against you or us if there's a claim of negligence. So the most important take-home message about consent, and I'm going to go into it in a little bit more detail, is that it's a process. It's not this one-off thing or the piece of paper that the patient signs. We accept that all adult patients with decision-making capacity have a right to accept or refuse our treatment, and we have a duty to respect their choices. And this right is grounded in both the moral principle of respect for patient autonomy and in the legal doctrine of informed consent. If you're going to provide care, you need to get consent for everything you do, including blood transfusion and blood donation. It can be verbal or written, implied or explicit. Verbal, implied consent is if I approach you with a blood pressure cuff and you hold out your arm, that's you giving implied consent. I don't need to ask you verbally or you say, yes, you may take my blood pressure. If you're approaching a patient with a syringe and a needle to take blood, or with a big needle to get a unit of blood from them, you need to ask them if they will give you permission to do that. And they will say yes or no, and that's verbal consent. Now, if it's more serious, generally you should have a written consent. Or if it involves anesthesia or surgical procedures, again, explicit written consent. There's no specific legislation on consent in Jamaica when it comes to blood transfusion. Many regions of the world and many facilities have specific forms. I know University of the West Indies, the hospital, University Hospital, has a specific blood form to either give or withhold consent for blood. And I assume the government hospitals do as well? Yeah. Same thing. Interestingly, in the United Kingdom, they don't have consent forms for blood transfusion. That's not to say they give blood without consent. They must give consent as outlined, get consent, informed consent, as outlined by the General Medical Council booklet on good medical practice. And you make a note in the docket that you've got consent, but the patient doesn't have to sign anything. So really, if you've explained it well, you really shouldn't need a form. But to cover ourselves, we have tended to go down that route. But as you'll see, that doesn't help you if you haven't actually explained. For informed consent to take place, there are three things. The patient must be competent, the patient must be given sufficient information to enable them to make a decision, and they must not be acting under duress. Now, competency is assumed to be present, and is the ability to comprehend, retain the information, especially the likely consequences of having or not having the treatment. And the patient must also be able to retain that information in their head and weigh it in the balance. What is the age of consent in Jamaica? It's actually 16. At 16, the patient can give or withhold permission to receive the blood products from you. They have to be competent. We assume all adults are competent. So anybody above the age of 16, we assume that they're competent. Although, do remember that that's an arbitrary number picked by the lawyers and the judges. They say, all right, over the age of 16 you have sense, less than the age of 16 you don't. But you all know people under the age of 16 who are very intelligent, 14, 12 even. And you all know people over 16 who you wonder how they get up and get out in the morning. They have autonomy. And the refusal, if they decide to, doesn't have to make sense to you. And you'll see where I'm going with that shortly. They can say, I don't want it because it's a Thursday. No blood on a Thursday, definitely not. And you have to say, all right, well, I'll give it to you tomorrow then, after you explain why they may or may not benefit or get worse. And this intelligence or this making sense is all based on logic. And the logic, I put in this slide, I didn't always have this slide here. Logic can be defined as reasoning conducted or assessed according to strict principles of validity. And an argument is valid if and only if the truth of its premises entails the truth of its conclusion, and each step, sub-argument, or logical operation in the argument is valid. Another way of putting all of that is that a logical argument or logical thought process is something that makes sense, and you can explain how it makes sense, and it always makes sense, and the outcome will always be the same. And I'm going to expand on that and why that is important. You need to give them information. You need to give, generally speaking, for any medical procedure or intervention, full disclosure of what you're doing, why you want to do it, how you're going to do it, who is going to do it, why it's good for them to have it. Complications, things that can go wrong, or burdens, which is another good word. So it's not so much a complication, it's something that's going to happen that the patient may not like. And then the risks involved. Possible additional procedures, not so relevant in blood transfusion, but might be. You need to tell them the consequences of having or not having the treatment. Also alternatives, and in our setting, the cost. Everything costs money now. Patients are in hospital, we have no drugs, so you say, here's a prescription, go and buy some drugs. We have no implants, go and buy the implants. We have no saline, please go and buy some saline. And we ran out of sutures last week. Please go and buy some sutures. For blood transfusion, before you transfuse any patient, you need to give them the reasons why you want to do it, what benefit they're going to get, how you're going to do it, the fact that it's going to need a big needle in their arm for them to get it, not a little one, because the blood won't go through it. Use lignocaine. The risks of the transfusion, consequences of the transfusion, and alternatives. And I'll have a slide on the alternatives as well. And you have a duty with every single patient that you give a unit of blood or any other blood product to go through all of this information. Before you say, we need to give you some blood, sign here. Which is what happens, isn't it? Medical students, isn't that what happens? Here, sign this form, we need to give you some blood. What? Yes, your hemoglobin is low. You're anemic. Sign. So you must consider the nature of the patient's condition, and you must understand what it is that the patient wants. You can't assume anything. So don't make any assumptions about what the patient may or may not understand, what their wishes are, whether they really understood anything you said to them at all. So you need to discuss it. Now, the Jehovah's Witness, and I'm paraphrasing here, and I'm leaving out some of the difficult religious arguments, they believe that blood represents life and is sacred to God. If you remove it from the creature, the only use of blood that God has authorized is for the atonement of sins, and you mustn't eat it or transfuse it. If they are given the blood, they believe that they have dissociated themselves from their religion. For those of you who are Christians and believers, this is a serious thing. This is a very bad thing. Not only that, is that all the other church members and family members will stop talking to them. So it's not something to be taken lightly. What are the alternatives? Complex slide, I think it's legible from the back even though. They will acceptable, what is not acceptable is they don't want any whole blood, including autologous blood. They don't want red cells, platelets, white cells, or plasma. They will accept crystalloids, sugar and water, salt and water, and synthetic colloids, including dextrans, hetastarch, hemocell. And they always come with information about blood boosters. These other things I've mentioned are the blood substitutes. They will come with it to hospital. And have a big form as well, by the way. If you think the consent form is complex, they have a big long form saying why they don't want blood, and signed by a lot of people. Some things are allowed sometimes depending on how they really feel about it. Albumin, immunoglobulins, some vaccines, hemodilution, where you dilute the blood, take it away from them, keep it connected to the body, and then give it back to them at the end of the procedure. So you need to tell them all about all of this stuff, and then get their permission whether or not they want the blood. You must tell them about less serious side effects, if they might be of great significance. So with every unit of blood you transfuse, there is in fact a risk of death. How many of you tell patients, we need to give you this blood because your blood count is low. You might have some funny reactions like itching, sweating, fever, hepatitis B, hepatitis C, although we've screened for it, unless it was a few years ago. And you must also tell them everything that is common and some things that are very rare. So not the short list, the long list. It takes a little time. In fact, more than a little time, but you have to do it. Always use clear, simple, and consistent language, and avoid bias, and check that they understand what you're saying. Often it's good to get them to repeat it back to you. Also, everybody who is practicing whether medicine or nursing, you have to stay up to date with the latest medical nursing information, technological information. As you found out from Dr. Mills a little while ago, things change fast. And if you're not up to date, you can't give the patient the information they need. Finally, on consent, they must then give their permission freely and without coercion. They say, yes, thank you, I would in fact like a couple units of blood. These are some of the things that happen frequently: manipulation, coercion, and duress. Manipulation is when you're giving them the information, you don't tell them everything. You conveniently leave out things like death and hepatitis and the possibility that they can get feeling really sick, or transfusion-related acute lung injury, which we see in intensive care. So you don't mention that because you really want them to have the blood so you can quickly sign off the form and go back to bed. Coercion is when you say you really, really, really should have this thing. It will really help to make you better if you have the blood. If you don't have the blood, you're probably going to get worse. So you should have the blood transfusion. That's coercion. If they ask you, what do you think, doc or nurse? You can give them your point of view, but you must be objective. You need to say, if I were in your shoes, I might take the blood, or I would take the blood, or I wouldn't take the blood. But then you can't then say, so therefore you must. You always throw back at them, but the final decision is yours. Duress is, you need to have the blood to have the surgery. If you don't take the blood, I'm not giving you the surgery, and I'm going to discharge you from the hospital. So now you're putting pressure on them. Anybody who works at university, the other threat is, if you're not taking part in anything that I say, we're going to transfer you to KPH. No disrespect to KPH. Or if you're at KPH, they say, we're going to transfer you out. You're not allowed to do that. So the forms that you see really don't serve any purpose unless you've gone through that long discussion. Even after they've signed the form, the only thing the form does is confirm that probably you and them were in the same room at the same time one day. You have to do it as your usual and common practice, so you always have these discussions. So let's go back to the patient. Based on everything I've just told you, can I see a show of hands of those who will let her die?
And those who will not transfuse.
It's the same thing. Okay. There's a fine difference between not transfusing and let her die. Hands up all those who will not transfuse her no matter what. And you still have some people who are going to transfuse her, really? What if she changes her mind? She can change her mind at any time as long as you haven't put her under duress or coercion. So she can look at you and say, I would like the blood. However, what is required before you actually give her the blood after she says, I would like the blood? There's something else that has to be present. You must have a witness. She doesn't actually have to sign. I will make a note afterwards that she said yes with the witness, and make sure you have a witness. And that happens from time to time. When you're having the discussion, when I'm having a discussion with the patient preoperatively, first thing you have to do is make sure the elders and the family leave the room, because they will put her under duress. Second thing is you have your witness, and you outline the pros and cons, as we've just said, of having or not having the blood transfusion. And if she says, you know what, doc, if you think I need it, give it to me, then that's okay, but document it. So, realistically though, if she still says no, and we have a patient right now in intensive care who's a Jehovah's Witness, whose hemoglobin is 5 point little bit, who needs a number of surgical procedures. And we have to have this discussion with her and her family, but primarily with her, as to whether or not she's going to get the blood, whether she will accept it, and the very serious fact that if she doesn't have the blood, it increases her chances of a bad outcome, including death. And that's what we've said to her. So, the other stuff as well. So that's informed consent for blood transfusion, which is one of the big ethical things, especially with the Jehovah's Witness. And there are other scenarios that I could throw in, but in the interest of time, I won't. But it's also important for the donors to be looked at from an ethical point of view. As you've heard this morning, in all circumstances, blood donations should be voluntary and non-remunerated. You shouldn't coerce them. Coercion takes place in this country when they say, your wife is going to have a baby, you need to give 2 units of blood. Or your friend, partner, spouse is scheduled for surgery and we're not going to schedule the surgery until we get 4 units of blood. Now does that still happen? I'm not on the wards anymore. And you can say, we would very much like you to donate some blood because the blood bank is short. So please try and get some. But you can't say we're not giving you the surgery until you get the blood. And the donor should provide informed consent. Do you get written consent from your donors? But you do, after you've given them all the pros and cons and thank you as to why you're doing it, they should give permission for you to take a unit of blood from them. This hasn't come up, but the whole blood bank service should not be profit driven. I suspect that's a joke anyway, but it is possible that you could work it in a way to try and make money off people, but you should not do that. You must ensure anonymity between the donor and the recipient, except in special situations. It is possible that a person would like to donate some blood for someone. That is fraught with difficulty that you can explain better than I can. But at all times, the donor information must be kept confidential. The actual donation criteria should be based on regularly reviewed medical criteria. There should be no discrimination of any kind. And by the way, when I said the informed consent from the donor, the same thing we mentioned, explain why, complications and risks, the fact that the needle is very, very big. And the blood in every situation should be supervised by suitably qualified registered medical practitioners. So that doesn't mean they have to take the blood, but there must be a physician involved in the process, supervising the whole thing. And finally, the entire process must be in compliance with appropriately defined and internationally accepted standards, which I know we're doing here. And if anything goes wrong, you must have a long discussion with either the donor or the recipient as to what happened, why it happened, how sorry you are that it happened, and measures that are going to be put in place to avoid it happening again in the future. Also remember that blood is a public resource and access should not be restricted to anybody. And we should also avoid wastage. Don't drop the blood after someone has been kind enough to donate it. Thank you.